Well, I think this is a very big issue and a long discussion, so we need a lot of time to elaborate on this. But systemic fat emboli syndrome is something which you don't want to see as a clinician in any of your patients because it's life-threatening, it's very difficult to manage, and always causes anxiety amongst ourselves and triggers usually departmental and multidisciplinary and sometimes national discussions how to handle each case separately. So there aren't, as you might be aware, any unifying guidelines as to how to manage the multi-fat emboli syndrome, simply because of what I said just now, that every case can be very different and every case is handled and responses to the treatment differently. But key message here is a few clear-cut messages, I suppose. One, this is something that we most commonly see in patients of milder phenotype and genotype. So usually it's seen in SC, compound heterozygote sickle cell patients, or patients with hemoglobin-SS or S-beta-thalassemia who have a milder clinical phenotype altogether. So people who haven't had a lot of problems in their lives from the sickle point of view. Number two message is that early introduction, early treatment with red cell exchange transfusion to radically bring down the sickle burden is and can be life-saving. And it's really, the timing of it is very crucial. We should not be sitting on those cases waiting for them to get better without, and omitting or delaying to do an urgent red cell exchange transfusion. Plasmapheresis, there are no guidelines and there are no randomized controlled trials to support this, but we have had our center as well as the other center I published with, but also other authors and other clinicians have had various experience with plasmapheresis, but some of us more positive experience than others. So this is something that indeed it's an intervention that should be considered in certain patients, especially those who do not respond quickly to red cell exchange transfusions.